name is Fred Trotter. I'm a healthcare data journalist. This is Niall Brennan, who is with me, who is almost kind of he's a data person, certainly. Probably some of your recent work counts as data journalism. Anyways, we're streaming from Datapalooza. The idea is to create some free content for patients who are not able to attend for whatever reason. And so we wanted to try to get some of the speakers and the kind of people that you could see in the hallway at Datapalooza, on camera. Just had a bunch of patients in the room. So this will be a totally different thing. We're going to talk a little bit more geekily about Medicare data, Medicaid data, Medicare Advantage data, claims data generally, which is what I work on for my day job as a day journalist. I spend a lot of time in those areas. And I'd like, if you don't mind, for you to introduce yourself and explain how we know each other.
Yeah, absolutely. Thank you, Fred. Well, first of all, I am a patient. We're all patients. But I'm Niall. I currently work at a startup based in San Francisco called Clarified Health Solutions. I've been in that role about 14 months. Prior to that, I was the CEO of the Healthcare Cost Institute from 2017 to 2022. And prior to that, and possibly the role that many people, at least at this conference, know me for, is when I was Chief Data Officer at CMS during the Obama administration. But I've been fortunate to have lots of other cool jobs in my life at MedPAC and CBO, the Brookings Institution, Urban Institute. I was a mailman, bartender,
I don't know that part.
Carney.
So I can know when the jokes began here. Bartender makes sense. Mailman is a surprise.
Mailman, yes.
Okay.
So,
cool. So I access data every day through what feels like a giant spreadsheet, but is in fact a system called VRDC.
Mm-hmm.
And my company is one of the CareSet systems is one of the earliest adopters of VRDC. That was one of, from my perspective, Now's greatest accomplishments. The VRDC system at OEDA, which is the Office of Enterprise Data Analytics, is that right?
Yes.
The primary purpose of that is to allow for access of the government agencies. So the Social Security Administration needs to access Medicare data, they use VRDC. When the FDA does, they use VRDC, so forth and so on. But they decided to allow innovators on the outside to do that, and you had a huge part of that, which is, of course, I think the details of what made you famous. But you also participated in some huge firsts in terms of public use files and other things. I think there's a huge amount of work that you will never probably get credit for that was very important in terms of reform and kind of changing how things actually worked. But there are this kind of sign point things that had your name on them that the outside continues to see and draw value from. That's part of what made you famous. And you won an award for that.
Yes.
Congratulations.
The Data Liberator Award.
Yeah.
Perhaps an award that you too have won, Fred?
I did. And I won it in part for data that you got me, which means maybe sort of you won it twice.
I'll take it.
So,
yeah.
So, Datapalooza is a place where we celebrate the use of data in the patient interests. And I'm really proud of the work that I do and then CareSet works does generally for that. Your organization, the one you currently work for, has done some amazing things. I just wondered if you could cover some of the things that I've seen you tweeting about studies that you've released that have some pretty substantial impacts. Is that okay? Can we talk about that?
Yeah, totally. So, I'm still, relatively new in the role, but I'm having a lot of fun. Clarify is a really great company. Data is at the center of everything that we do, and in a way, it fuses my two previous previous roles into one. When I was at CMS, I was Lord and Master, I use the words loosely, of Medicare data. In particular, I went to the Healthcare Cost Institute, where we had a lot of data for people with employer-sponsored coverage, commercially insured. And then you come to an organization like Clarify that has, data, payer complete data on, over 200 million people, partial data on 300 million people. So, all Medicare fee for service, about 35 million Medicaid managed care, and about 120 million people with employer sponsored coverage. So when you have that much data, it just creates some really unique opportunities to build products and do things with the goal of making healthcare more efficient, and hopefully in ways that enhance and improve care at the patient level. One of our sort of taglines is that we light up patient journeys, because we've linked a lot of this data so we can follow people across time. We can take a physician-centric view and look at all the care that a physician is providing, and try and create performance metrics and different things like that. So obviously we're a commercial organization. We sell this software to payers, providers, and life sciences companies. We sell the insights generated from our software. But in addition to the operational roles I have, I launched and lead the Clarify Health Institute, which is meant to be the public-facing, more pro bono thought leadership part of Clarify Health. And I operate completely independently of our commercial focus. Occasionally there will be Venn diagram overlap, because a lot of the problems that need to be solved in healthcare are problems that Clarify can help solve. So in particular, I would from a Clarify Health Institute perspective, and we can dive in on anything else in any way you want, Fred. We did release, I think, 3 really high impact analyses in the latter part of 2022. The first one tracks pediatric mental health trends, and we leverage both our commercial and Medicaid data to try and bring some hard data to, you literally, you cannot open a newspaper or turn on the television or, get on Twitter as you are now, without people talking about, the mental health crisis among our children, sort of a perfect storm of, 2-3 years of pandemic life, social media toxicity, existential dread around, climate change, and dysfunctional political systems, et cetera, et cetera. So, so that was our first big piece, and it documented just some really, depressing trends in pediatric mental health. There was I'm blanking on the numbers a little bit now, but I think there was a 60% increase in mental health hospitalizations among children from 2016 to 2021, and a 20% increase in ED visits. Second piece we did, which is I'm not sure, I know several people are talking about it in the hallways at the conference, but we're analyzing the new payer rates transparency files, and we're very involved in that, again, for primarily commercial reasons, but we did release a brief called "Confronting the Zombie Rate Apocalypse."
Zombie rate. Oh, that's interesting.
Because this data is a real example of be careful what you wish for, and payers have chosen, I think, to release the data at such gargantuan scale that it, candidly strains the capability of even extremely sophisticated, companies with decent budgets like Clarify or CareSet or whoever. Humana alone Humana's data is contained in 4 million different files across 4 million.
Oh, really? I hadn't looked at that. I had no idea it was that bad.
It's astonishing. So, and they're not but that's just one example. The United Healthcare data is multiple terabytes. So all that just becomes a huge challenge. And what we found was one of the reasons the data, there's several reasons why the data is so big, but one of the reasons the data is so big is that there's just a lot of zombie rates. So payers are reporting a negotiated spinal surgery fee for a clinical laboratory, and vice versa, a clinical lab rate for a spinal surgeon. And so it just leads to tons and tons and tons and tons of data.
I see. So now, do you think that this is malicious? Do you think that they're creating a haystack so that they don't have their needles coming out? Or is it just a side effect?
I don't want to ascribe ill intention to the actors involved, but
I can describe.
I do.
You can describe, and I will ascribe.
I do think. And they might even say, look, we're just following the data schema that, CMS outlined. But this is certainly not what anybody, and what nobody, the only people who could have intended this would be people who wanted it to become incredibly difficult to derive insight from, data that people have wanted to know for so long. So yeah, you can see it there on the laptop. So there's literally billions of zombie rates. Okay. And then there are also, let's say that a payer has a payer is acting as a TPA for, a national payer is acting as a TPA for 10,000 employees nationwide.
Yep.
Okay.
Yep.
And let's just take one DRG, 470. Okay. For one hospital. Okay.
Yeah.
So instead of saying our negotiated rate for employers is $10,000, and it's like one line of data, they say our negotiated rate for CareSet is $10,000, and our negotiated rate for Clarify is $10,000, and our negotiated rate for Boeing is $10,000. And so you just get, again, thousands and thousands of lines of data for each discrete DRG or HCPCS code. And yes, you can dedupe it and things like that, but it literally
is this a big data cleanup task that's pretty massive.
It's massive data, not big data.
And it's not, because most of these records are duplicates or non things. It is like this zombie term. Is
they are the
graphic, by the way. That's a beautiful graphic. Yes. The zombies, you turn codes into zombies. I think that's,
So
that's very nice.
One of the things I'm very fortunate. Clarify is a great place to work. It's a lot of really talented people, and going from a small nonprofit that actually also did
punched right above his weight.
Fantastic data visualizations and stuff like that. But we literally have some people internal to Clarify on. There's a design team. They don't just work with me. They work on our products and things like that. And I just give them very crude data in Excel spreadsheets where I say I'd really like the cover to have angry diagnosis codes. Can you make that happen? And they make it happen. So yeah, that's great.
That's brilliant.
And then the final one is we did a piece on surgical volume. Linking it to
let me go back here.
Linking it to a whole range of outcomes, and the fact that high volume or orthopedic surgeons and this has been around for a long time.
Yes, it's a classic phenomenon.
And really, in part, had some of its roots in the public use files that I released when I was at CMS. But the thing is, knowing Medicare volume only gives you an inference of an overall surgeons' volumes. So we wanted to, revisit this issue, confirm the very strong link to outcomes and spending. So lower costs, better outcomes with higher volume surgeons. And just generally have it out there as a call to action that maybe this information should be more widely available, because people can disagree, and I'm actually not necessarily super gung ho on the give patients information and have them navigate the healthcare system, because I think that's the healthcare system sort of abdicating responsibility for a lot of problems that they created, and the patient is bears the brunt of the problems. But it's just such an easy thing to grasp. Do you want to go to the hip surgeon who's done 50 or 500? And if you can show that the one who's done 500 has a readmission rate that's half the rate of the person who's done 50, that's a no-brainer, right? You don't need a PhD or a fancy data viz or anything, right? It's just it's not the perfect combination, but it is sort of like looking at Yelp, or the number of if you've got an Uber driver with a 4.95 rating and 10,000 rides, you feel a lot more confident than somebody with a 4.8 rating and 200 rides. Yeah. So that's some of the stuff that we've been doing on the thought leadership side of things.
It's very cool.
Yeah.
So I hope that's what's happened, is that the entire time you've been talking, the stream has been able to see some of the stuff that
I hope so too,
that you've been talking about. But I will try to get those links out. I've been saying I'm going to try to get links out. I wonder how I'm going to do that. So this is going live on Twitter. It's going live on YouTube. It's going live on LinkedIn. I thought I would ask
millions of people.
Well, I mean, millions of people eventually will see this, because we're putting it out permanently.
Okay.
Right. And in the year, 2241, I'm sure these YouTube videos will be kicking around, and so maybe then a million will happen. But it's probably going to be a trickle.
Yeah.
Until then. But
we can just hope that all the Russian bots are busy.
Yes, that's right.
It.
Some it may not be human intelligence that gets us over to 1 million. But the point of this is to make sure that patients have access to the kind of rich content. I think that's a perfect example of 3 studies that are using clinical data that is claims-based data. And of course, both
vast amounts of data.
Exactly, vast amounts of data, but also data that is, I would say, in terms of clinical granularity, relatively low. It's a side effect of the billing system. We're handling this data. I think both Clarify and Caraset do a pretty good job of making sure that we are not doing what we are doing in a way that causes privacy problems. And so this is relatively safe analysis in terms of the downside.
Yep.
And when I say relatively safe, I mean mathematically safe.
Yep.
It's the probabilities are astronomical that anybody would ever be re-identified in this data. And the other thing is, it's what I love about what you've been tweeting, and we haven't chatted so long. All I've seen is your tweets.
Yes.
Which is really.
This is what happens when Fred moves to the town that you live in.
I've been meaning to.
And never calls.
Give me a break. I still have unpacked boxes. Not just with random stuff, unpacked boxes with things I need every day. I'm going into boxes. As long as that's true, I haven't really moved here. And but I do live in DC now, and I've been to call you, and I invite you over for dinner soon. I can hold 4 people in my apartment.
Sweet.
And
remember when we hung out at one of my son's baseball games? He made the All-Star team or something, and it was
very exciting.
Right off of it was near Howard University.
Yeah.
Yeah.
You had me over dinner twice.
Yeah.
You literally showed me your trophy before I had a trophy and said, "Here's the trophy I have that you don't have." That was the experience. That was my takeaway from dinner. Was that experience. So we should hang out more.
Yeah.
But I think the other thing is it's perfect evidence of coming to Datapalooza, and I don't know. I mean, I think the conference is changing, and there's less people here. There's obviously less patients. I think it's still one of the most patient-centered conferences. I think though this might be the future. We might be just doing a lot more of this streaming. Which one? There's lots of cases.
Mighty Casey.
Mighty Casey couldn't make it.
Oh,
I
bummer.
think she had car trouble.
Okay.
Is what I heard, but I don't know for sure. So I was looking forward to seeing her. She's,
Mighty
she's so
Casey,
often
if you're
here.
out there, hi.
Yeah. Hello. Hey, Mighty Casey. Actually, let me see. I think this is the one that would show us. This is the view. It's a little bit delayed, but it shows us the comments here. So if she shows up, we'll let her know. And the other thing is, I wonder if we got a phone number. Maybe we'll call her. Anyways, my point.
Yeah.
My point is, it's really it's amazing to come to Datapalooza and find out, you've been working on real problems. And what are the impacts? Do you think the people change? Do you think there's going to be less zombies as a result of your zombie article? Or
well, you see, so that's a classic example where I would hope that some of the things we're finding, and we're not the only people, contributing insight in this space. I really do for these files to be useful going forward. CMS needs to listen, and they need to change their data schema to just really kind of put parameters around what.
Exactly?
How it should be reported.
Yeah. Did you put some suggestions in your paper?
We're assembling, some suggestions, sort of coupled with examples of,
egregious.
very egregious problems.
Yeah.
And, again, there are other folks opining in this area too.
Yeah. Okay, good. So Datapalooza, a good place to complain with productively.
Yeah, and it was really great. Coming in this morning, I think there was a Datapalooza last year, but I wasn't able to attend. It's just, I don't know, other people might find this obnoxious, but I just like to walk in, and within 3 minutes, I've seen, 28 people that I know, many of whom I haven't seen in 3 years. So it's been really nice being here today and being a part of it again.
Yeah, no, I really like that. I come here, I can see people. Some people like yourself, I can't really avoid. That's a downside, of course, but you do what you can, to give old friends some shit.
Try being an actual part of my family and being totally unavailable to avoid them.
That's good. That's good. So I wanted to thank you very much for coming on the stream. I think we'll cut it short. Unless you don't want to talk about something else you're doing that's fun and interesting, I think, or we just wait till next time and give another update.
I think we wait till next time.
All right, sounds good. So with that, thanks for listening, and we're going to go back and maybe see if we can get some more ice cream. And they moved there it is.